more. Joining us now in the studio is National Coordinator, Rotary International Project on National Planning Campaign, Professor Dolapo Lufadeju.
Correct.
Oh, great.
You got
it. Nice to see you, Professor.
Thank you.
Nice to see you, and Happy New Year.
Thank you very much. Thank you. Happy New Year.
Yeah. Now, when it comes to maternal mortality, childbirth, and all of these things, over the years, Nigeria has not really fared well for someone to, beat his chest to say, yeah, I'm proud of what we are doing, either as a state government, either as a federal government, or even agencies. And there has been a lot of assistance from international organizations concerning this. Exactly. Why are we still where we are?
Thank you very much. First of all, thank you very much for bringing this very important subject to the public domain.
Thank you.
Ordinarily, childbirth and pregnancy should be a thing of joy in the family. But when it becomes a source of sadness, then it becomes a problem. At the moment, what you just said about people acting and working to reduce maternal and infant mortality in Nigeria has not had any changes. But it is now changing. The federal government of Nigeria, through the Federal Ministry of Health, is implementing a policy on maternal and perinatal death surveillance and response, MPDSR. And MPDSR has become a tool by which we are seeing a lot of reduced trends in maternal mortality in the country. MPDSR looks at the maternal statistics, and Rotary International, which I represent in Nigeria, has introduced a web-based system where you can collect real-time data on maternal statistics. Before, we didn't know what was happening in our facilities. There was no way of knowing what is happening in an hospital 1,000 miles away. But now you can see everything on your computer. And that has created, because of that awareness that has been created, and the fact that people will see the data coming from your facilities, there is a lot of competition that has been generated in facilities now to be able to remove themselves from the scourge of maternal mortality. As you said, we are losing close to 60,000 women as a result of childbirth and pregnancy complications. And we are losing 515 women from every 100,000 births in the country.
All right. Ours is a patriarchal society, and issues of girl-child education has always come to the fore. And some have said that because of education, some persons do not understand pregnancy spacing, which also causes some form of complication. How does education in this aspect complicate or increase the figures?
First of all, education is power. Information, they say, is power. The first thing to do is actually advocacy at the level of government to improve education, like you said, girl-child education, everybody to be in school. That's number one. Number two is to have community dialogues, platforms that will inform parents, particularly heads of household. It's not only a question of women. Fathers, head of household, must be educated on the need to give children the type of education that they will, especially when a child becomes about 30 years of age, you have to begin to let them know about sexual education, to delay forced pregnancies. There are many types of pregnancies that are very, very risky. Yes. The ones that are too early in life, the ones that are too late in life, too many, or too close.
All right.
We have to campaign against all of these.
All right. So much to learn from these issues as we get along. Certainly, the conversation will continue. Thank you very much, Professor, for coming on the program.
Thank you very much. God bless you.
Right.
Joining us now is the National Coordinator, Rotary International Project on National Planning Campaign, Professor Dolapo Lufadeju. Good morning. Thank you for joining us on TVC.
Thank you for having me.
Now, I'd like for us to start from the point of view of what we just read, talking about the government seeking to reduce maternal mortality to about 288 per 100,000. How do we go about this?
I would like the government to aim at reducing maternal mortality to 0 in the country. That will be a much goal to look forward to.
All right.
But it starts like this. When a woman is pregnant, I think the most important thing to do is to get skilled advice at the clinics, at the maternity wards, to go for what we call antenatal clinics. That time, they will be able to check her, and she will return maybe ever so often on the detail of delivery. Then she can deliver safely. But if, for instance, a woman is pregnant and he has not gone for antenatal clinic and is delivering at home, then all the complications that arises from there, they do not have any control over. And therefore, there could be complication. You have to go to the hospital at that time. It's too strenuous, and it can lead to disastrous effects. So women
all right, in our society right now, we have traditional birth attendants, and there are people who are quite enlightened, who know all of these things, but they say that is what we have been used to. I give birth to my first child with the traditional birth attendant. Nothing happened. The second, nothing. So they just feel it's a normal thing to do.
Yeah. If you have been doing something over and over and you are successful, there will come a time when there will be a problem. When a pregnancy is coming as a bridge birth, where the normal pregnancy is head first, and then the child brings leg first. And these TBAs are not technically equipped to do cesarean section or to rotate the fetus in previous visits to antenatal clinic. That you cannot have labor for more than 12 hours, normal labor. And if she continues to press delivering such pregnancies, complications will continue to increase until the woman gets, blood pressure or is bleeding, and then they have to rush her to the hospital. Don't forget, there are no ambulances to take her from home to the hospital. The hospital is a far distance away. Maybe they put her on a Okada or Keke pipe. You can see a pregnant woman in labor on motorcycle, on rough road. It is excruciating.
But there are certain areas where there is a limited number of skilled personnel for this, especially in rural areas who, patronize people, traditional birth attendants. And we also have a shortfall in terms of maternal clinics. Don't you think that all of these are the things that are giving rise to people, trying to patronize what is readily available to them?
Yeah, that is why now the federal government is trying to upgrade primary health care centers. In every ward of this country, there is a primary health care center. Those primary health care centers have been upgraded to be able to take maternity issues because they are closer to the community. Yes, we don't have enough skilled personnel, but we can train the birth attendants to encourage the women to go to antenatal clinic so that their pregnancies will be monitored. And as far as we are concerned, the deliveries at home, a lot, more than 70% of births are happening at home where there are no facilities to support any complications. That is where the problem comes. If a pregnancy is presented in a normal form, there is no problem. But when it is now complicated, and the TBA does not take action immediately, we call them 3 delays. The delay at home to refer this woman to the hospital immediately, after 12 hours of trying. The delay then when you go on the road, this bad road and distance to the hospital, then when you get to the hospital itself, there's a 3rd delay there, where, like you said, no facility, no bed, not even skilled personnel in the hospital to attend to you. So those 3 delays we are campaigning against to stop them. If you can stop 3 delays, work on the 3 delays, and if you can campaign and create public awareness on the risky pregnancies, those pregnancies that are too early in life, 13, 14, 15 years of age, those pregnancies that are too late, above 40 years, And those pregnancies that are too close and too many, one after the other. You know, and all of this you can use modern contraceptive facilities to be able to space children.
All right.
Thank you, Professor Olufadeji, for your time on TUC Breakfast.
Professor Dolapo Lafadeji, it's good to have you join us right now.
Thank you.
Thank you so much.
Thank you very much.
Now, a lot of effort has gone into and is still going into reducing maternal mortalities in Nigeria, especially when you look at what United Nations, different foundations, even Rotary Club, Rotary International, and all of that are doing. Talk to us about some of these strategies, especially the one that is web-based, that you know, data is being collected in real time. How is that helping, and how is that the way?
Thank you. Rotary International in 2008 started what we call quality assurance in obstetrics, where we are looking at the quality of the structure of our facilities, the quality of the process, and the quality of the outcome. At the same time, in 2013, the federal government started a policy program called Maternal and Perinatal Death Surveillance and Response. The quality assurance in obstetrics and MPDSR look similar. So Rotary International approached the federal government for a collaboration to bring it together, and we took the guidelines of MPDSR, government policy, to our counterparts in Germany. Rotarians and the German government supported the funding to develop this web-based program called electronic platform. It's this electronic platform that is now been placed in Nigeria. For the past 2 years, we have put all the secondary hospitals in the country on the platform. We have put all the tertiary hospitals on the platform. And now we are in the process of integrating community MPDSR into the platform. What is the basis of this? How does it operate? We have trained medical record officers in all our hospitals to be able to collect data on the Android phone. That is the difference. The Android phone, more than 90% of Nigerians use the phone. We didn't buy computers, we didn't buy iPads that's so expensive. So MPDSR electronic platform is very cheap to run. And the system is so robust and friendly that it's easy to train the medical record officers. When they press, after putting the data, they press a button on their phone. That data goes to the HMIS officer at the state level, Health Management Information Officers. And then when they get all the report of the facilities on their phone, they press the button, the data is automatically analyzed and report is automatically generated. This is the first time it's happening in our country.
And with this now, it helps the response level.
Yes, and then this data also goes to the Federal Ministry of Health. So what it has done now, it has opened up the system and the operations and maternal deaths, notification and reviews at the facility level in the country. So the commissioner in the state can look in this computer and see the performance of all its hospitals.
In real time?
Yes, real time.
Okay. Yes. Thank you very much, Professor Dolapo Lafadeji. Thank you so much.
Thank
for
you
coming.
very much.
Right.